In this lecture, we will be discussing orthopedic surgery procedures for the lower limb. This follows on from another lecture which focused on the hip. We will now elaborate on the evidence concerning the efficacy of total knee replacement or total knee arthroplasty for the treatment of knee osteoarthritis or knee OA. Total knee arthroplasty, also known as total knee replacement, is one of the most commonly performed orthopedic procedures. Total knee arthroplasty consists of resection of the diseased articular surfaces of the knee, followed by resurfacing with metal and polyethylene prosthetic components. As of 2010, over 600,000 total knee arthroplasties were being performed annually in the United States and were increasingly common. Among older patients, the per capita number of primary total knee arthroplasties doubled from 1991 to 2010 in the US, from 31 to 62 per 10,000 Medicare enrollees annually. Compared with total hip arthroplasty, total knee arthroplasty is associated with higher rates of post-operative complications and lower patient satisfaction, with up to 25% of patients remaining dissatisfied with their post-operative outcomes. These low satisfaction rates highlight the importance of patient education. Informing patients about post-operative outcomes will ensure that their expectations from the procedure reflect the available evidence. Total knee arthroplasty is usually performed on an elective basis and should only be considered after exhaustion of appropriate non-surgical therapies and extensive discussion of the risks, benefits, and alternatives for this intervention. For the properly selected patient, however, the procedure results in significant pain relief, as well as improved function and quality of life. The tibiofemoral joint or knee joint is a complex hinge, primarily allowing flexion and extension in the sagittal plane, with some degree of rotation and gliding. Damage to the synovial joint of one or more of the three compartments of the knee, including the lateral, medial, or patellofemoral compartments, may be the result of a variety of pathologic conditions. The indications for total knee arthroplasty generally include local knee joint osteoarthritis, inflammatory arthritis, or post-traumatic arthritis. Similarly, total knee arthroplasty is warranted in the presence of a tumor, if there is avascular necrosis of the osseous structures of the knee joint, or if there are congenital joint abnormalities. However, over 95% of total knee arthroplasties in the United States are performed for osteoarthritis. Before proceeding with total knee arthroplasty, a multifaceted regimen of non-operative treatment should be tried. Non-surgical treatments offer significant benefit with lower risk. The efficacy of these non-surgical interventions, even with advanced osteoarthritis, has been supported in clinical trials and are appropriate, particularly in patients looking to avoid or postpone surgical intervention or for patients not fit for surgery. It's worth noting at this stage that, contrary with some anecdotal evidence, individuals such as long-distance runners who have a long history of moderate to vigorous activity throughout their lifespan do not have an increased risk of knee OA. Next, we will review some of the contraindications to total knee arthroplasty. Total knee arthroplasty should not be performed in the following clinical settings: where there is active infection, where the patient has a non-functioning extensor mechanism. Such instances might include a patient with neurologic disease affecting the lower extremity, where there is chronic lower extremity ischemia, if the patient is skeletally immature. This is important given that the physes near the knee are the major source of growth for the lower extremity. Finally, patient participation in any type of post-operative rehabilitation program, monitored or independent, is essential for a successful outcome following total knee arthroplasty, and an inability to participate may constitute a relative contraindication to this form of treatment. Next, we will review the preoperative evaluation for total knee arthroplasty. Assessment of operative risk prior to total knee arthroplasty includes verifying the severity of the underlying knee pathology and failure of non-surgical treatments, as well as identifying any comorbidities that might impact the choice of surgical procedures. The majority of total knee arthroplasties are performed under elective circumstances, for which there is adequate time to consider alternative treatments, assess surgical risk, and to make any necessary adjustments to medications. The preoperative evaluation begins with ascertaining the patient's symptoms, their treatment history, and any relevant psychosocial factors.
First, the patient's symptoms should be documented. At this point, it is critical to document and investigate any history of concomitant back pain, often described as hip pain by the patient, hip pain, often described as groin pain by the patient, or numbness, paresthesia, or pain in the leg. The presence of back or hip symptoms, or indeed any symptoms in the leg, may indicate that knee pain is referred from these sites. Neurologic complaints can arise from peripheral nerve root or central nervous system disorders. The clinician must also inquire about calf pain or claudication, which could indicate peripheral vascular disease or spinal stenosis. Next, the location of the pain, whether it is localized to the medial, lateral, or patellofemoral compartments. Its severity and its effect on the patient's activities of daily living and quality of life should be determined. Aggravating and relieving factors should also be elicited. Regarding the patient's treatment history, previous interventions for knee pain and their effectiveness should be noted. These might include weight loss regimens, use or non-use of non-steroidal anti-inflammatory drugs, whether they had any glucocorticoid injections, and whether they undertook formal, prolonged physical therapy. Psychological health testing has been advocated to identify prospective total knee arthroplasty patients with higher levels of pain, anxiety, and depression on validated scales. The physical examination typically follows the patient interview and includes an assessment of a number of outcomes. Range of motion is normally assessed. Maximal active and passive flexion, particularly of the knee, and extension should be recorded and any joint contracture noted. Any gross deformities, for instance varus, valgus, recurvatum, or flexion contracture, should be noted and definitively assessed with radiographs. The presence of crepitus and pain on loading of compartments should be noted. A ligament examination should also be conducted. Preoperative assessment of the stability or degree of contracture of the knee ligaments, including the collateral and cruciate ligaments, is important. Evidence of collateral ligament incompetence may indicate the need for a more constrained prosthesis, and the posterior cruciate ligament may either be retained or sacrificed at the time of surgery. The anterior cruciate ligament is sacrificed in the majority of total knee replacement designs, and therefore its assessment is not considered to be important for most implants. An examination of the spine and hip region should also be conducted, as it is important to exclude referred pain to the knee originating from these regions. Elicitation of the knee pain with straight leg raising or with hip motion, especially internal rotation, should raise suspicion and warrants further study, including imaging of the lumbar spine, hip, or both. A neuromuscular evaluation should be used to gauge motor strength and tone in the entire lower extremity, with special attention devoted to the quadriceps or extensor mechanism. In addition to checking motor strength, sensory and deep tendon reflex assessments, specifically of the patella and ankle jerk responses, should be performed. The patient's gait should be observed, and an antalgic gait, otherwise known as a limp, is often apparent. An antalgic gait is characterized by the patient spending a shorter time bearing weight on the affected side because of pain. Another feature of walking gait often observed in patients under consideration for total knee replacement is a knee thrust, an abnormal medial or lateral movement of the knee while walking, usually associated with a varus or valgus deformity. The patient may also have a Trendelenburg gait, where they shift their torso over the affected hip. A positive Trendelenburg sign during gait is suggestive of hip joint disease or weakness of the gluteus medius muscle. In a patient with Trendelenburg gait or test that is positive, hip or back pathology must be excluded before total knee arthroplasty is considered. After the inspection of the patient's gait, their distal pulses, including their dorsalis pedis and posterior tibialis pulses, should be assessed. The final part of the physical examination involves an assessment of the patient's skin, which should be thoroughly inspected for any abrasions, ulcerations, swelling, scarring, redness, vascular changes, or infections. From the physiotherapist's perspective, since most patients presenting as candidates for total knee replacement are older, specific attention should be paid to the patient's comorbid medical problems and symptoms that may reflect underlying comorbidities that need to be considered prior to undergoing total knee arthroplasty. For instance, obesity is an important consideration. While there is no weight limit for performing total knee arthroplasty, most surgeons would be concerned about performing a procedure in any patient with a body mass index or BMI above 40. Obese and morbidly obese patients may be at a higher risk for perioperative and long-term complications. However, such patients are not denied surgical options, given their often debilitating osteoarthritis. Weight loss prior to surgery may help to reduce the risk of infection and other perioperative complications, and reduce the risk of surgical revision. Another important consideration is whether the patient smokes. Smokers are at increased risk for developing surgical complications. In a review of 8,776 patients who underwent total knee arthroplasty, 11.6% were current smokers, and, compared with non-smokers, smokers had increased rates of any wound complication, deep infection, pneumonia, and reoperation. Therefore, smoking cessation is advised at least 6 weeks prior to surgery to at least 6 weeks post-operatively, although lifelong cessation is preferred. Finally, it is important to reiterate the importance that the patient must thoroughly understand the benefits and risks associated with total knee arthroplasty. While the primarily sought-after benefit of total knee arthroplasty is pain relief, improvement in function and quality of life is often reported to be higher compared with pain relief. In spite of a good surgical outcome, up to 25% of patients may remain dissatisfied. Dissatisfaction following total knee arthroplasty surgery can be reduced as a result of extensive discussion and explanation before surgery. We will discuss the outcomes and traditional determinants of surgical success later, including mortality rates, complications, the need for reoperation, and the longevity of the implant. But here, let us discuss some of the patient-centric outcomes specific to total knee arthroplasty that should be discussed with the patient in the lead-up to surgery. Regarding the extent of pain relief that can be expected following total knee arthroplasty, a systematic review documented that approximately 20% of recipients of total knee replacement report persistent or recurrent pain in the year or so following surgery. Some of these patients are nonetheless satisfied, but it is important for patients to bear in mind that the risk of less than complete pain relief is not trivial. Research is ongoing to identify risk factors for a suboptimal outcome. Regarding function, patients generally experience dramatic improvements in the capacity to perform daily and community activities. Patients with worse functional status preoperatively tend to gain the most function following surgery, while patients with the best preoperative function tend to achieve the highest level of postoperative functional status. While activities of daily living are generally easier to perform due to decreased pain following total knee arthroplasty, objective measures of knee function, like range of motion, typically improve less. The postoperative motion that can be expected is highly dependent on preoperative motion. Then, when it comes to the correction of deformities, patients with preoperative range of motion deficiencies should be counselled that the best predictor of their postoperative range of motion is their preoperative range of motion. Knee flexion contractures can be reduced in most cases by appropriate component selection for surgery and by soft tissue release. Improvement in varus or valgus deformities is usually achieved.
The final point of discussion is that the patient must be aware of and be fully able and willing to cooperate with the rigors of the rehabilitation process following total knee arthroplasty, as these are not trivial.
The introduction of the total condylar prosthesis by Insall and colleagues in 1972 is generally considered to mark the era of the modern knee replacement. This prosthesis was the first to replace all 3 compartments of the knee. There are many variations of the original design, with the modern-day prosthesis representing a modular evolution of Insall's original design. All total knee arthroplasties consist of a femoral component, a tibial component, and a patellar component. During the surgery, the diseased articular surfaces of the knee are resected and resurfaced with metal and polyethylene prosthetic components. Designs can either retain the posterior cruciate ligament or remove it, Most currently used designs involve resection of anterior cruciate ligament. Fixation techniques involve either using cement to fix the prosthesis to the bone or relying on bone growth into and onto the prosthesis surface. These are known as cemented or cementless procedures, respectively. The cemented procedure essentially involves exposing the anterior part of the knee joint, displacing the patella, and removing damaged or arthritic parts of the knee to shape the heads of the femur and tibia. Bone holes are drilled into the bones to allow for placement of metal components. Replacement metal articular plates are then fixed to the bones using polymethyl methacrylic cement. A polyethylene surface is applied to the tibial plate to assist non-abrasive articulation with a metal femoral plate. The polyethylene plate is then cemented to the articular surface of the patella to improve articulation. In a cementless procedure, the anterior part of the knee joint is exposed and the patella is displaced, with the removal of the damaged or arthritic parts of the knee to shape the heads of the femur and tibia, as in the cemented procedure. Bone holes are drilled into the bones to allow for placement of metal components. Metal replacement articular plates composed of porous metal are then impacted onto the bones without using cement. A polyethylene surface is applied to the tibial plate to assist non-abrasive articulation with the metal femoral plate. Contact of this porous metal with the bone stimulates osseointegration, forming a strong, direct bone-implant interface. Whether the chosen procedure is cemented or cementless, to control bleeding from the cancellous bone and intramedullary cavity during drilling, a blood pressure cuff or tourniquet is sometimes placed on the thigh during the initial setup. It is not typically inflated until after prepping and draping the patient to reduce the amount of inflation time, and it is typically deflated just prior to closing the wound. The total tourniquet time for the majority of knee specialist surgeons is approximately 60 to 90 minutes. The proposed benefit of the tourniquet is a clean operative field, not complicated by blood. However, the use of a tourniquet may increase the risk for postoperative venous thrombosis, increased pain, thereby increasing medication requirements, and reduced early range of motion and potentially a delay in early rehabilitation. Indeed, a meta-analysis of randomized trials reported intraoperative blood loss was less in the group using a tourniquet. However, in studies where the visible blood loss or calculated blood loss was reported, the results were similar between the groups, and transfusion requirements were also similar. Nevertheless, the overall rate of complications was higher when a tourniquet was used, and it was concluded that total knee arthroplasty without a tourniquet led to overall better outcomes. So what is the best approach? Cemented or cementless? There is no consensus on implant choice, and there is a wide variation among nations, states and cities, and individual surgeons. The variability of implant design and technique makes it difficult to analyze and generalize reported results. National joint replacement registries are enabling the analysis of survival rates of joint replacements to be calculated based on revision surgery if it is performed. For example, the Australian National Joint Replacement Registry publishes its results every year in great detail, with the 2019 report being based on the results of over 780,000 knee replacement procedures. Postoperative management includes pain management, prophylaxis against venous thrombosis or thromboembolism, minimization of postoperative morbidity, and appropriate physical therapy to achieve the best possible knee motion and return to full function as safely as possible. Patients are generally mobilized the day of surgery, and with the aid of a physiotherapist can usually walk with assistive devices post-op day 1.
The length of hospitalization varies from 0 to 5 days, depending on comorbidities and local practice. Total knee arthroplasty is trending towards being performed on an outpatient basis in selected low-risk patients and with discharge to home directly rather than to a rehabilitation unit.
The first signs of clinical improvement compared with preoperative status generally occur between 6 and 12 weeks post-op, with full recovery occurring between 1 and 2 years post-op. Regarding rehabilitation, there is no clear consensus regarding the optimal frequency, duration, or intensity of physical rehabilitation protocols for total knee arthroplasty patients.
However, participation by the patient in a post-operative rehabilitation program is required for successful outcome following total knee arthroplasty. A well-structured physiotherapy program that includes range of motion exercises, gait training, quadriceps strengthening, and training in activities of daily living is an important component of the rehabilitation process.
Interventions that attempt to preserve knee motion include the use of pillows under the operative foot while in bed to maintain extension and to avoid flexion contracture. Active and passive exercises to achieve maximal flexion should be instituted early with appropriate use of analgesia to minimize pain. Realistic expectations on flexion range should be based on preoperative flexion, and average flexion of total knee replacements around the world is around 115 degrees. Range of motion exercises should be started as soon as possible. A 2007 meta-analysis of 5 randomized trials concluded that participation after discharge from hospital in a functional exercise program supervised by a physical therapist improved knee function and range of motion in the short term when compared with routine care. Inpatient rehabilitation has not been shown to result in improved mobility compared with home-based physiotherapy in patients who have undergone an uncomplicated total knee arthroplasty.
The typical follow-up schedule following total knee arthroplasty starts with wound review within 2 weeks of surgery. This can be done by an internist, nurse practitioner, rehabilitation doctor, physiotherapist, or the surgeon. The patient typically sees the surgeon at 6 to 8 weeks with or without a repeat knee radiograph, and subsequent follow-up is highly variable.
In the long term, patients are encouraged to pursue low to moderate intensity, low impact activities, as patients who are more active do appear to increase their risk of needing revision arthroplasty.
Walking, swimming, and moderate physical activity are always encouraged for maintaining strength and physical and mental well-being. This level of activity should be expected following total knee arthroplasty. Sports can be allowed within reason after appropriate rehabilitation. If the patient had a moderate level of sport prior to surgery, then it may be continued with advice that the joint will have a higher load and possible wear. In this final part, we will discuss the long-term outcomes following total knee arthroplasty.
Mortality following total knee arthroplasty is low overall, ranging from 0.5 to 1% per year, and is primarily related to pre-existing medical comorbidities. Surgeon volume impacts surgical outcomes, as there is evidence that low-volume surgeons and hospitals are associated with worse outcomes compared with high-volume surgeons and hospitals.
Complications associated with overall morbidity include those in common with other surgeries, such as anesthesia or blood transfusion, venous thromboembolism, and surgical site infection, as well as complications specific to operations involving the knee joint, including neurovascular injury, prosthetic joint infection, peri-implant fractures, patellofemoral disorders, and issues related to wear and tear of the prosthetic.
Reoperation may be needed for a variety of problems related to overall implant wear, aseptic loosening, implant infection, patellofemoral disorders, or peri-implant fracture. Loosening of the prosthesis is the main reason for revision.
Males have a higher revision rate, mostly secondary to higher rates of infection. For patients with primary osteoarthritis, the revision rate in Australia was 5.3% in 10 years and 8.6% at 18 years. The longevity of the implant largely reflects the total load that the implant bears over time. In general, younger Overall recipients use their implants at a more active time in their lives, and thus the devices are much more likely to fail in their lifetime compared with the implant in older patients. The impact of patient age on the likelihood of needing revision surgery was evaluated in a large population-based study including over 50,000 patients aged 50 or older who had undergone a total knee arthroplasty between 1991 and 2011.
The lifetime risk of revision surgery in patients who had a total knee arthroplasty over the age of 70 years was approximately 5%, with no difference between men and women. However, the lifetime risk of revision increased with decreasing age, with the highest risk of 35% observed in men between the ages of 50 and 54.
The risk of surgical revision appears to be even higher in patients under the age of 50, suggesting that total knee arthroplasty should be undertaken cautiously in these patients.
In another population-based study that included over 120,000 patients, almost 5% under 50 years of age required revision at 1 year. Obesity also has a negative effect on outcome after total knee arthroplasty. In a 2012 meta-analysis, patients who were obese had increased rates of infection and revision for any reason compared with patients who are not obese.
Implant infection may result in prolonged hospitalization, the need to remove the infected implant, and an extended course of antibiotic treatment, followed by reimplantation. Up to 1% of total knee replacement recipients experience an infected prosthesis over the course of the first postoperative year. Prolonged infection treatment may lead to multiple surgeries, fusion, or even amputation. And that concludes this lecture on total knee arthroplasty. In this lecture, we provided an introduction to total knee arthroplasty, the indications for it, the preoperative evaluation, the surgical procedure itself, the postoperative care, and its long-term outcomes. This lecture was prepared for students enrolled in the UCD School of Public Health, Physiotherapy and Sports Science. Images were taken from the Complete Anatomy software prepared by 3D4 Medical.